Manish sir, please start. Thank you. Manish sir, can you hear us? Kindly start.
Yeah, ma'am. Yeah. Hi, welcome all. I'm Dr. Manish Tiwari, Professor in Pediatric GMC Nagpur. I would like to welcome all of you for this great initiative by Dr. Sheikh sir for the case scenario in which an unknown case is presented to our presenters and the moderator, and they will guide us to a diagnosis. So, with the help of under the initiative of Dr. Sanjay Pakune, our President Maha AP, and our Secretary General Dr. Amol Pawar, we have started this program. I would request Dr. Pakmode sir to please share his insight regarding this program.
Namaskar. Good evening. Welcome to the MahaIP platform. This particular program, be the Sherlock Holmes, cracking down the difficult cases, sometimes the simple cases also, but even that too needs wonderful presentation and then the moderation, and the experts are doing all the great job of exploring and reaching to the diagnosis. So here where there is a curiosity is always there, what is the final diagnosis? But so means every mind is here, means you have to think, and when the presenter present the case, and when the experts are cracking the case, they should have the qualities of like Sherlock Holmes. Now, why this particular character Sherlock Holmes was chosen? Because Sherlock Holmes was he was known for his great meticulousness, and as he used to solve the cases, he was having a very keen observation, and all these things were leading to solving the mystery. Here we are using this particular character, as our experts are also doing the same job by presenting a history by a presenter and moderator. Our expert are cracking the case with their experience, with their analysis, and with their keen observations, and keen hearing, and whatever that history told by the presenters. So this is a particular MahaIP program, which, because in these days we are dependent on Google. Whatever we need, we don't think, just Google it and do it. But here we really make our mind to means to think first what it can be, what it will be. Rather, all the attendees also are thinking on that, means are thinking what will be the final diagnosis. So with this, I invite you all to the MahaIP platform, and this is a really wonderful activity of MahaIP. Today, I welcome all the experts. Dr. Harish Bhayati sir from Vidarbha only, from Washim. Sir is known for his roaring practice, and now sir has joined the medical college also. So you must know he's a great combination of a great practitioner plus academician, which is rare to find sometimes. Means very rare cases we find both the things are there. But sir has proved he's having such a roaring practice, a big hospital, and now the institute joined the GMC Washington as a professor. So welcome you, Harish Bhayati sir, and Dr. Uh, from Ambijoga is Dr. Mundada, Dr. Shiv Prasad Mundada sir from Medical College from Ambijogai as the experts, and Shishir Mirgunde sir as a moderator, and Dr. Pranita as a presenter. I welcome all the office bearers of MahaIP, our dynamic secretary, Dr. Amol Pawar, then the scientific, Dr. Minha Sheikh sir, our scientific chairperson, and Dr. Sanjay Deshmukh, convener, Dr. Pankaj Agrawal as a vice president, Dr. Rishi Lodia as a editor, and Abba Sonone as a treasurer, and other EBs and CIAP EBs who have joined for the today's program. I also welcome Dr. Manish Tiwari, who is conducting the today's session. So Manish is always kind to us because he's helping us in a lot of our projects whenever we need. Manish is at there. So thank you, Manish, from bottom of our heart. And I again giving a good luck to the presenters. And we know definitely our experts will be doing the great job. And let's have a wonderful academic bonanza, one more academic bonanza for Mahaip. Thank you. Thank you so much. Over to you, Manish.
Thank you so much, sir, Sanjay sir. I would now request Dr. Amol Pawar, our Secretary General, to share his views regarding this program.
Thank you, Manish sir. First of all, I welcome senior faculties from Dr. Dr. Harish Bhaiti sir from Washim, and also the other expert who is also senior faculty in Bezugai from Latur, Dr. Shivprakash Mundada sir, and also the moderator, today's moderator, my dear friend Dr. Shishir Mirgunde sir from Kolhapur, and also Dr. Pranita, who is junior resident of MD Pediatric at CPR Hospital, Kolhapur, and all the Maharashtra IIP office bearers, President Dr. Pakmude sir, Meena Sheikh sir, then Ravindra Sonone sir, Sagar Wag sir is there, and Sanjay Deshmukh sir, and all the all the office bearers of different branches and all the attendees, PG students. So this is very nice initiative. Since last 3-4 years, we are conducting such type of activities, cracking the cases, the Maha Epic Case Challenge, and then now this year be the Sherlock Holmes, crack the case. Already Sanjay sir has explained in detail about what is the theme of this program. So I wish all the best to Dr. Pranita, and I also wish all the best to Dr. Harish Bhaiti sir, senior faculty from Washim, uh, and Dr. Shivprakash Mundada sir also. And congratulations, Dr. Shishir sir, for accepting this task of case presentation with the help of Dr. Pranita. So wish you all the best and wish you all happy learning to each one of you. Thank you. Manish sir.
Thank you so much, Amol sir. Now I would request Dr. Sanjay Deshmukh sir, our convener for MahaAP, to please guide us.
Good evening. Extremely sorry, I am driving due to emergency. But as rightly said by our president, Dr. Pakmade sir and Dr. Amol, this is the every Friday we look after to listen to some interesting cases. And today we have uh, our own Dr. Harish Bhaiti sir from Washim. Dr. Pakmade sir told he is a man of practice and dedication. He's practicing since years in Washim. And I was fortunate to visit his big hospital, which is like a metro city hospital there. And Dr. Mundara sir from Ambujogai. And my best wishes to Dr. Mrigunde sir and Dr. Pranita. So I hope everybody will try to crack the case before the time. So thank you, and best wishes.
Thank you, Deshmukh sir. Now, for today's session, we have our expert, Dr. Harish Bhaiti sir. Sir needs no introduction, no more introduction, as already Sanjay sir has introduced him. Sir is a leading practitioner at Washim. Sir is Professor Emeritus at GMC Washim right now. The other person, the other expert, Dr. Shiv Prasad Mundra, I was his intern when Sir was JR at IGMC Nagpur, and I have worked with him for many years. Sir is a great academician and a very good practitioner. For today's session, Dr. Shishir Mirgunde sir, who is an associate professor at GMC Kolhapur, he will be moderating the session. And for presenting the case, Dr. Parinita Khandekar, who is a junior resident in pediatrics at GMC Kolhapur, she will be presenting the case. Over to you, Shishir sir.
Good evening, everyone, and thank you, MahaAP, for giving us opportunity to interact with esteemed faculties for such academic fest. And congratulations, MahaAP, for organizing such interesting event. So let's start without much wasting time. So this case being presented from CPR Hospital, Kolhapur, under RCSM Government Medical College. And this being government hospital, there are some resource restrictions and some obstacles, but still we do manage difficult cases and try to go to proper diagnosis. So Dr. Praniti will present an interesting case today. Dr. Praniti, you can start.
Very good evening, everyone. Myself, Dr. Pranita Parashram Khandekar, third year resident from RCSM GMC and CPR Hospital, Kolhapur. And we will be presenting a case under the guidance of Dr. Shishir Mirgunde sir, Associate Professor at RCSM GMC, CPR Hospital, Kolhapur, and our respected HOD ma'am, Sangeeta Kumboskar ma'am. So let's start the case. So there was one patient, 9 years old male child, resident of Ratnagiri, born out of non-consanguineous marriage, second by birth order, and he was brought with chief complaints of vomiting since 8 days, yellowish discoloration of eyes and skin since 6 days, fever with chills since 4 days, and rash was present all over body since 1 day. So these were the chief complaints. So any preliminary thoughts over this chief complaints?
Whether the symptoms, the sequence of the symptoms should be more important in this case.
Yes, sir.
So what were the sequence?
Sir, initially the patient had vomiting for 8 days. Then after that, he developed yellowish discoloration of eyes and skin, which was noticed by mother, which is present since 6 days, and fever with chills since 4 days, and rash was present for only 1 day.
Pranita, sequence of event was started with vomiting itself
Yes, sir.
or fever?
Yes, sir. Initially, vomiting was there.
Any specification for vomiting, bilious, non-bilious?
It was non-bilious vomiting, sir.
Food? Yeah. Any urinary complaints?
No, sir.
Color of the urine you ask upon?
Yes, sir. Actually, initially on day 1 of admission, urine color of the urine was normal.
हाँ आप आगे जाइए.
Okay, yes. So, after considering all these chief complaints, our differential diagnosis, like initially were viral hepatitis, like fever, vomiting, and jaundice was there, as described by mother. Leptospirosis could be there because jaundice and rash was there, and dengue with hepatitis we consider because fever, vomiting, and rash, and malaria because chills and jaundice and fever was there.
What I feel is that there is no, to start with, there was no fever. So all these diagnoses cannot be at the first place. All this differential which we are saying comes with fever first. Okay, are you audible?
Past history, any illness related to GIT, Pranita?
Yes, sir. There was history of a loose stool like 15 days back with abdominal pain, but the stool color was normal. That it was not blood stained.
And she presented to you with vomiting itself. That time,
Yes,
no
sir.
fever.
Sorry, sir.
That episode of gastroenteritis you said 2 weeks back, does
Yes.
it have any fever or anything that time?
No fever was there, sir. Only loose motions were there, but for 2 days, totally like 4 to 5 episodes, and it got subsided on its own. Child did
Medication,
not take any treatment for that.
medication given that time, 15
No,
days
sir. No
back?
any medication was given at that time.
Okay.
Shall I proceed, sir?
Yes.
Yeah.
So history of present illness, vomiting was non-projectile, total 4 to 5 episodes per day, non-bilious. No history of any outside food consumption associated with pain in abdomen, and he had taken some Ayurvedic medicines like before getting admitted to our hospital, like for like on day of like illness 4, because he had a history of jaundice as mother noticed. So and loose stool history was there 15 days back, which lasted for 2 days. Total like 4 to 5 episodes. Stool color was normal, no blood in stool, and after that, with these complaints, the child got admitted to civil hospital Ratnagiri, and that time they got the CBC done. That time the HB was 3.5, and he received one blood transfusion. And next day he developed a rash, after a rash all over body and predominantly over trunk, and which was associated with itching. And after that, the patient got referred to our hospital. Then on a second day of admission, that is on the 8th day of illness in our in our hospital, that time patient had one episode of cola colored urine, sir. So impression is like will summarize this case. 9 years old male child with complaint of vomiting, fever, yellowish discoloration of eyes and skin, with the history of loose stool 15 days back. And he had low HB. For that, he received blood transfusion prior to admission to our hospital. And following which he developed a rash all over body and also had one episode of cola colored urine. So, any extended thoughts over this, like sir?
Caste of the patient?
Yes, sir.
Caste of the patient, anything?
Sir, Maratha, Hindu Maratha.
Consanguinity, no.
Non-consanguineous marriage, sir.
History of Paika?
No, sir.
Any family history of receiving blood transfusion, consanguinity, anything like this?
No, sir. There is no family history of like receiving blood transfusion or any history, like any surgery.
Pranita, this blood transfusion was given for particular symptoms she went to hospital, or it was accidentally noted?
Actually, sir, that patient, 9 years old male child, mother noticed that patient is having jaundice, like the yellowish discoloration of eyes and skin. But when they went to hospital, like after examination, there was no jaundice as such. Paleness was there. So it was like perceived by mother as a jaundice, but only paleness was there. But on like a routine investigation, CBC was done. That time HB was low. That is why in Ratnagiri Civil Hospital they had transfused the child with 1 pint PRBC, and after that he developed rash and one episode of cola color urine was there. For that the patient was referred here, sir.
Pranita, that patient with low hemoglobin was moving and came to hospital for yellow discoloration of eyes only?
Yes, sir.
Or anything that time notice or you ask in the history?
Only vomiting, sir. Vomiting, fever, and this yellowish discoloration of skin and eyes.
And no
For
history
that only.
no history of pica by
No,
any
sir.
chance?
No, sir. Child was absolutely all right like 8 days back. Like except that 15 days back he had one episode like history of loose motions.
Pranita, the blood transfusion that time you had any reports? It had shown some platelets low or high, any that particular way?
Actually, yes, sir. Platelets were low. That time one like they had got the CBC done at Ratnagiri Hospital, civil hospital. That time the CBC was done. The HB was 3.5, WBC was normal around 6,800, and the platelet was 1 lakh.
Any urinary complaints?
Urinary complaints were not there at that time, except for that cola color urine, which was present after like getting admitted over here, sir.
Okay.
So, shall I proceed? So, like our DDs were like a few infective etiologies we consider and few non-infective etiologies. In infective, like leptospirosis, as a patient belongs to like Ratnagiri, where like lots of like paddy fields will be there, and malaria, which is also endemic for that. Dengue with hepatitis and acute viral hepatitis for just for ruling out purpose. And sir, non-infective etiologies, hemolytic anemias, because of post-transfusion hemolytic reaction could be there, G6PD deficiency as the patient is male child, and autoimmune hemolysis, and drug-induced injuries, toxic hepatitis due to Ayurvedic medicines. He had taken some Ayurvedic medicines for that jaundice thing, sir, like 4 days before getting admitted to our hospital. For 2 days, he had taken treatment.
Pranita, why you are not added HUS in differential diagnosis?
We have added, sir, in like further.
Because all symptoms presenting with gastroenteritis, 15 days gap, then vomiting. So I think in DD you should add HUS.
Yes, sir. Actually, here I haven't mentioned CBC yet, like
Okay.
like thrombocytopenia and all. That is why I haven't included it. I'll explain, sir, later on.
Yeah.
Yeah. Shall I proceed, sir?
Yes.
Then first further history points, negative history. There was no history of outside food consumption, no periodic rigors, no history of exposure to dirty water.
Pranita, sorry to interrupt you. I
Yes,
was on mute for a while.
Yes, sir.
To start with, the child has presented with vomiting, and then the component of fever has occurred.
Yes, sir.
And hepatitis or jaundice has been jaundice was the presentation before the fever, so it is less likely to be any infective cause. We have to relate this case with your previous episode of acute gastroenteritis or the some drug consumption which has been taken during that episodes.
Yes, sir.
So it appears to be a drug related or an acute gastroenteritis complications which is presenting now.
Yes.
Mainly complications like immunological reactions or and HUS type of reaction, which is the presentation of hemolysis and thrombocytopenia may occur if we go for a CBC in this case.
Okay, sir.
Okay, proceed further.
Yes, sir. So next, sir, there was no history of exposure to dirty water or paddy fields, no conjunctivitis, no calf pain, no retroorbital pain, no any bleeding manifestations, no similar complaints in the past or any drug allergy, no any past history of any drug allergy, no facial puffiness, no headache, and no oliguria as such. Then no history of repeated blood transfusions in the past, no history of worms in stool or perirectal bleeding, and no history of pica, no any significant family history, past history or birth history. Developmentally also child is normal. Diet history, child is taking adequate diet, mixed type of diet, and normal growth, and immunization is done as per schedule. So any more information is needed, sir?
Some dietary history.
So dietary history, child is taking
He has received blood transfusion prior to this episode also. Hemoglobin was 3.5.
Yes, sir. 1 day prior to our admission to our institute, sir.
1 day prior only she received
Yes,
blood.
sir.
Okay.
Yes, sir.
Yeah.
So on examination, child was conscious. Pulse rate was 90 beats per minute. Respiratory rate 19 cycles per minute. Blood pressure was 110 by 60 millimeter of mercury, lying between 50 to 90th percentile. He had severe pallor, no icterus, no lymphadenopathy, no cyanosis, no clubbing, no pharyngeal congestion, no conjunctival congestion, no macular.
Sorry, no interest?
Yes, sir, there was no icterus. Hello?
Yeah.
Yes, sir. Mother was describing it as a yellowish discoloration of eyes and skin, sir. So she could have mistaken it for pallor.
Okay.
Yeah. So that's what, okay. Then pallor was there, but no icterus. And there was rash, like maculopapular morbilliform rash, which was present all over body and which was predominantly present over trunk. And there was no petechiae or purpura.
Okay.
Then,
Any picture available?
yes, sir, it's there.
Okay.
Yes. And on per abdomen examination, sir, per abdomen was soft, tender hepatomegaly was present, 6 centimeter under right costal margin, and liver span was 10 centimeter. Soft consistency, round border, smooth surface, and no splenomegaly was there, sir. No ascites. And on CVS examination, S1, S2 was present and soft systolic murmur was present. RS was clear and CNS also, no any abnormality detected, sir.
So at the end of examination, what are the positive findings we are having is the pallor
Yes,
and
sir.
pallor and rash.
Yes, sir.
Right. Okay. The
And hepatomegaly.
abdominal pain which was present in the child, whether it was too acute?
It was not acute, sir. It was just like mild abdominal pain was there, sir.
Mild abdominal
15
pain.
days
Okay.
back. That also 15 days back. During
Not
that.
not during this episode.
No, sir, not during this episode. Only tender hepatomegaly was there, sir.
Okay. Any blood in stool?
No, sir. No history of blood in stool.
No history of blood in stool.
Yes, sir.
Okay. Okay. Go further.
So this was the cola colored urine. He had one episode of cola colored urine. We have compared it with the normal urines.
Okay.
And, we started IV fluids and empirical antibiotic cefotaxime was started. So any key takeaways like after?
Cola colored urine, we have to go further on this. Okay.
Yes.
The cola colored urine was secondary to the drugs which we have given, or it was a presentation?
Sir, after like when he received transfusion, that time he developed rash. For that he was shifted to our hospital. And on the like second day in the morning, like a patient came in the night, and in the morning he had one episode of cola colored urine. Before that, only one blood transfusion was given, and that's it, sir.
Okay, there was no acute abdomen and there was no history of a chloroquine or a primaquine or quinine
No,
given
sir.
in the urine.
No, sir.
No. Okay. Okay.
So on first day of admission, we got some lab investigations done. So complete blood count was suggestive of HB 5.2, WBC 9,200, platelet 1.2 lakhs, MCV 92, MCH 36, MCHC 32. Retic count was actually 1.2. So mistakenly. Retic count was 1.2. Retic count was 1.2. Sorry for that mistake. And peripheral smear was suggestive of normocytic normochromic RBCs. A few teardrop cells were there and few microcytes. And platelet were reduced on peripheral smear. And anisopoikilocytosis was there. Retic count was 1.2 and corrected retic count was 0.4. And thick and thin smear for the malaria was done. Rapid diagnostic tests were done, which was like negative for malarial parasites.
Pranita, LDH all done?
Yes, sir.
LDH?
So we have done like after all these primary investigations, sir.
Okay, okay. In PS, any specification cells wise, like malaria was negative, abnormal cells?
No, any abnormal cells were seen on peripheral smear, sir. After that, sir, renal function test, 275 BUN, 4.2 creatinine, and liver function tests were normal, sir. Total bilirubin 0.4, direct is 0.1, SGOT is 67, SGPT is 12. Serum albumin was 3.6, serum protein 6.6, and hepatitis A, hepatitis C antibodies were negative. HbS-Ag was also negative, and fever profile was negative for dengue, malaria, typhoid, and leptospirosis.
Urine output in the hospital was?
Urine output was normal, sir, 1.5 ml per kg per hour, sir. And there was no oliguria. Urine routine microscopy 2-3 RBCs were present per high power field, and urine protein was 2+. Some casts were seen. Urine protein creat ratio was 1.2. PTINR was normal, 15.3 by 1.3 INR, and APTT was raised, sir, 43. CRP was positive, 32. Serum electrolytes were normal. HIV testing also normal, and direct Coombs test, indirect Coombs tests were done, which was also negative.
So at the end of investigation, it appears to be an anemia, and that also non-hemolytic anemia, but retic count is low.
Yes, sir.
corrected retic count is also low. So it
Yes, sir.
can be a bone marrow depression type of anemia in this
Yes,
case
sir.
also.
Yes, sir.
Okay.
Yes.
What is WBC count? Go on the previous slide, please.
Sir, it was 9,200.
Okay, it was 9,200. And neutrophils?
Neutrophils were like, sir, 67% neutrophils. Rest.
If we can consider it as the all other three neutrophils and polymorphs are normal,
Yes, sir.
or it is something significance is there?
Yes, sir.
Any neutrophil count, any significance was there? Low
No, sir.
count or
It was normal, sir.
okay, okay.
Yes, sir.
Go further.
Yes, sir.
So,
Then, yeah. And sir, USG abdomen was done. Liver appears enlarged, hepatomegaly was there. Mild ascites, kidney size was normal. Stool for occult blood was done, which was negative. And G6PD levels were also done, which was normal, sir. So I'll summarize the case again. Yeah, he's the 9-year-old male child brought with complaint of vomiting with a previous history of loose motion with abdominal pain 15 days back, and low HB with history of jaundice and took some Ayurvedic treatment for the same. And rash is present all over body with the passing cola colored urine for 1 day following blood transfusion. And on examination, pallor is there, maculopapular rash, hepatomegaly is there, and on blood on investigations, HB is low, platelet count is low, so bicytopenia is there, low retic count, deranged RFT, and LFT is normal, normal PTNR, APTT is rest, and normal fever profile. So what are your perspectives like so far?
Pranita, you thought of bone marrow during hospital stay?
Yes, sir.
Done it or just thought of?
Yes, sir. We have got it done. I'll explain later on, sir.
Fine. How was course of illness in the hospital?
Sir, fever spikes were persistent, like during the course of illness, sir. Even though we were giving antibiotics, antibiotics. After that, sir, child was not like too sick looking. After giving like fluids and all, activity was like improvement was there. And sir, we got like serial lab investigations done. So I'll explain it. So RFT was on improving trend, and CBC was also, sir. Here we can see next day rash disappeared. Only 1 day rash was present, and cola color urine was only one episode was there. After that, there was no any repeat episode of cola color urine. Serial RFTs were done, which was in decreasing trend, improving, and CBCs were done. So HB level was persistently low. 5.4, 5.9, 5.64, and sir, WBC count dropped on day of admission 5 to 3,700, and platelet count dropped to 78,000. So this was kind of alarming thing here, because now child is having pancytopenia.
there was no lymphadenopathy or hepatosplenomegaly, right?
Hepatomegaly was there, sir, but no lymphadenopathy.
And no splenomegaly was also
No,
there.
sir, splenomegaly was not there.
And we have not done USG or X-ray chest to look for any lymphadenopathy which is not palpable.
USG we have done, sir. Only hepatomegaly was there, and sir, mild ascites was there, and no mesenteric lymph nodes, or chest X-ray was also done, which was also normal, sir.
So this appears to be an pancytopenia or bone marrow depression. Now we have to look for secondary to what? Secondary to infection or infiltration. So there is no hepatosplenomegaly or lymphadenopathy. So storage disorder and infiltrative disorders like malignancy cannot be suspected in this case. So it's most probably post-infection bone marrow depression is there.
Yes, sir.
Or a drug induced, which can be secondary to the Ayurvedic medications, metals, and all things which has been prescribed previously.
Yes, sir.
Okay.
So,
Dr. Pranita, sir was asking how was the course in the ward. So whether patient was persistently feverish.
Yes,
Fever
sir.
spikes were there?
Persistent fever spikes were there, sir.
So Dr. Shiv Prasad, whether this was some ongoing infection or some immunological process was going on, what are your thoughts? Whether still we are thinking about infective etiology or some secondary
immunological.
I don't think this is an infective process which is going on. The child is getting infection because of decreased immunity or decreased WBC count, secondary to pancytopenia. What I feel so. Present episode is not at all appears to be an infective etiology. This is the presentation of a pancytopenia secondary to some bone marrow depression due to previous infection or some medications.
Yes, yes.
And patient
Yes,
presented
Pranita.
vomiting, not with the fever, and it was intermittent. Basic complaints was present was with vomiting. And previous episode of gastroenteritis 2 weeks back. Points
Yes,
more
so
towards autoimmune or post-infective illness.
Right, sir. Right.
yes, yes. So all of us agree that this is less likely to be some common infective etiology. We have to think about non-infective etiologies in this
Right,
case.
sir.
Okay.
Right. Sir.
Okay, Dr. Pranita, continue.
Yes, sir. Sir, on further investigations, like on fifth day we did this CBC, which was suggestive of pancytopenia. Blood culture was sterile, and urine culture was positive for Klebsiella, and no hemoglobin urea was there. LDH was raised 2100, red tick count was 1.2, and serum C3 C4 levels were also normals. And serum ferritin also we got it done, which is raised 1500, and triglyceride level 345.
LDH was raised.
Yes, sir.
What are the normal values for LDH? Means raise, we have written raise. What is the normal value for LDH? Any idea? Am I audible?
Hello.
Am I audible?
Yes, sir.
What is the normal value for LDH range?
Sir, 200 to 400, sir.
Okay. Okay. So it
So
is
it
high.
is like, yes, sir.
Okay.
2100.
Okay.
Pranita, HLH was thought upon,
Yes, sir. We thought of it, sir.
done.
So we thought of HLH, sir.
Yeah.
And like these are our few considerations. Like cytopenias were there initially, bicytopenia, now pancytopenia is there with low red counts. So we considered it could be because of some like marrow underproduction, or if non-effective hemolysis. And there was no hemoglobinuria, so it is less likely intravascular hemolysis. Ferritin was raised, which is acute phase reactant, and could be because of macrophage activation. LDH was raised means there is increased turnover of RBCs, and sir, APTT was raised with normal PTINR. So there is could be some intrinsic pathway issue or early DIC or lupus anticoagulant. So these were our few DDs, like bone marrow failure syndromes, like aplastic anemia secondary to like some post-viral infection. Hemophagocytic lymphohistiocytosis we considered, infection related marrow suppression, some malignancy like for ruling out purpose, and post transfusion reaction. That rash and this cola colored urine could be because of post transfusion reaction, sir. So any other things like to be considered here, sir?
Course of the illness, improving fever and all those things.
Yes, sir.
With
Fever, like this must be the day of admission 8 or 10. Like it is going on. Like we were doing all the investigations. So on 8th day, like fever spikes were reduced, but still it was present, sir. Like 1 to fever spikes will be present throughout the day. And sir, RFT was improving, as I said earlier. And but CBC was like pancytopenia was there, sir.
Pranita, how do
Count
you
was.
treat the patient?
Yes, sir.
How treatment management you had done
Treatment
there?
IV fluids only we were giving, and sir, Taxim we had started, C4 Taxim. as a until we got any further diagnosis.
Bone marrow, you said you have done?
Yes, sir, we have done bone marrow. So we planned bone marrow studies. So in that, the pathologist like commented like some hemophagocytes were there, sir. So considering like this is the criteria for the HLH, sir. So out of that, like one or two of the below, like if criteria are fulfilled, like molecular diagnosis consistent with HLH or any diagnostic criteria, like 5 points out of these eight. Among that, sir, fever was there, persistent fever spikes, and splenomegaly was not there. Cytopenias were there, like more than two cell lines were affected. Hypertriglyceridemia was there, hemophagocytes on bone marrow, and ferritin was raised. So total 5 points were like fulfilling, and extra point is hepatomegaly. So mostly splenomegaly is mentioned everywhere in this criteria, but here we have got hepatomegaly.
Yeah, it appears to be HLH. Good diagnosis.
Yes, sir. Then, sir, further, just to like see, look for the type of the HLH. So, if whether it is, and for HLH treatment, we have given steroids, sir.
Pranita,
And
CSF was done?
yes, sir.
CSF?
CSF was not done, sir.
Okay.
Sir, why did you ask about CSF?
Sir, HLH and infective etiology, there is close correlation. We find many of the viral meningitis or all those things, 2 or 3 cases.
Yes, sir. What could be the other differential diagnosis for HLH?
Sir,
So we started the standard treatment in this case. We started with steroids and IVIG as a supportive treatment, and patient responded well. Hello,
Okay.
Pranita.
Okay.
Yes, sir.
Okay.
Okay, so
Sir, for
is it
further,
typical?
yes, sir.
Okay, what happened later?
Sir, after that, for just for look for the type of HLH, whether it is like primary or secondary, the secondary sepsis or something. For that, we got whole genome exome sequencing done. So it was like suggestive of this ADAM TS13 mutation, sir, which was heterozygous. So the final diagnosis was thrombotic thrombocytopenic purpura.
Yeah, what final diagnosis is thrombotic thrombocytopenic purpura,
Yes,
and
sir.
that has been leading to HLH, right?
Coexistent with HLH, sir.
Coexistent with HLH.
Yes, sir.
Okay. So clinically, where there is no thrombocytopenia.
There is thrombocytopenia, sir.
Okay.
Initially, the platelet count were like 1 lakh, 1.2 lakh. After that, 78,000.
The rash, no, that was along with pancytopenia, right?
Yes.
But the rash was for only 1 day.
1 day.
1 day.
We consider it must be because of, sir, like post-transfusion reaction, sir, which was there along with cola urine.
How can Dr. Shiv Prasad or Bhayati sir, how can we explain this rash and especially rash? Because thrombotic thrombocytopenic purpura or HLH, it's a rash, and the rash we saw in the picture, that type of rash we don't get in HLH or TTP. So
probably
what?
vasculitis manifestation of the disease process, and HUS moves simultaneously similar type of diagnosis in the mind. Vasculitis probably caused this rash, sir.
But why to correlate TTP with vasculitis? It has nothing to do with TTP. Vasculitis has nothing to do with TTP. So most of the viral infections like CMV or EBV or simple flu or sometimes HIV patients also can precipitate with TTP. That's what literature says. So
Yes.
that rash could be just simple viral infection that precipitated this TTP for which this child was prone to. So this TTP, they have given report in zygosity as heterozygous. Homozygous patients' presentation is more severe. Heterozygous may not have that much, and that ADAM-TS 13 activity. So that is almost absent. And despite that, patient didn't have very aggressive course because of heterozygosity. So this was actually this TTP is a very unusual diagnosis in pediatric age group. Usually it presents in adults, especially in pregnant women, and rare in pediatric age group. And commonest differential diagnosis is atypical HUS. Atypical HUS. Everybody of us must have thought initially atypical HUS.
Yeah,
And atypical HUS.
we are feeling any jaundice as long as it has been presenting with rash and post-infection presentation like an immunological reaction type. But it turns out to be it's a rare mixed presentation, I think so.
TTP as such is a very rare disease to occur in children. And
Right,
atypical
sir.
HUS, everybody should consider. But surprisingly, the important clue for that diagnosis, cystocytes on peripheral smear, was absent in this child. That's why we were
Never
misdirected.
thought of TTP.
So what was the features of TTP here in clinical features?
Sir, persistent fever spikes were there renal clinically, sir.
Clinical features of TTP.
Sir, there
Yeah.
was no disturbed neurological function, sir.
Yeah.
So
Because
fever
TTP,
only.
TTP is essentially what is called as MAHA, micro angiopathic hemolytic anemia,
Yes, sir.
MAHA. And TTP and HLH is a rare coexistence. It can happen. It can happen. It's a rare coexistence. Yeah, that's a good case. Yeah.
And the neurological presentations are more common in TTP rather than renal presentations.
Yeah,
Renal
because
presentations are common in atypical HUS.
we have what is called as TTP and TAMOP. So in TAMOP, you have more of renal involvement. In TTP, you have more of CNS involvement.
Neurological.
Yeah, and TAMOP and TTP, both the treatment is plasma exchange.
Plasma exchange. But
Okay,
in
so
this case, we didn't require plasma exchange, and we discussed with hematologists also. They said
yeah.
heterozygosity is the cause for such a good recovery. They advise the mycophenolate mofetil as immunosuppressant,
MMF.
and patient, yes, MMF, for to which patient is doing well.
Yeah.
Patient didn't require plasma exchanges.
Sir, child has taken treatment for 6 months. Steroids we had given after that mycophenolate phenolate, and right now patient is not having any complaints. And CBC on discharge, what sir? Like we discharged that patient on day of admission 17. That time CBC was HB was 11.7, WBC 5,600, platelet 2.7 lakh, BU and creatinine was also improved. And recently the child had visited hospital. That time also the CBC was sir normal, and RFT was also normal. And child is also doing well. He's not having any complaints right now. And we have like completed 6 months of treatment. Like MMF we have given for 6 months.
Oh, nicely managed, Shishir sir.
Yes,
It was nicely
this was,
managed case.
but
Congratulations,
still
sir.
this child may have recurrence because TTP is not that much mild diagnosis. We have to keep monitoring this child because he may again recur and may have different presentation.
Yeah.
So
Shishir sir, any role of ecospirin in this case or prophylaxis of aspirin?
no.
No role.
There is
Because
no
it's
role
a
of.
phenomena is thrombotic, no?
Yeah. So here pathophysiology is ADAMTase deficiency. ADAMTase enzyme has role in its normal function is to disintegrate multimers of von Willebrand factor. If it doesn't disintegrate these wall membrane factors, then platelet aggregation will increase and that this MAHA will occur. So this is the
Okay.
pathophysiology. Even if we give aspirin, all these things, it will not work because basically
Okay.
problem is ADAMTase deficiency. So there is no
Okay.
role of any antiplatelet agents like aspirin or any other.
Okay. So what
Being
any
yes,
prophylaxis is recommended in this child?
no, being genetic disease,
Okay.
no. We have to treat
Nothing
its
specific.
recurrence.
Shivaprasad sir, nothing specific.
Nothing specific.
Nothing specific. You have to be careful with regard to his symptoms, particularly two symptoms. One is neurological, second is renal. Serology is more
Yes.
common in TTP, so we have to be careful with regard to confusion and lethargy and any CNS symptoms. If the child is getting that, consider this is TTP in action and then treat accordingly. Especially the immunomodulation with regard to plasma exchange and or rituximab and other therapy. Yeah.
Yes, people recommend
Okay.
etoposide, steroids, and cyclosporin.
You know, the interesting part of this, both of these diseases, if you allow me to, if you allow me to summarize, so TTP and HLH, the core pathophysiology as told by the physicians is Adam 13 deficiency, wherein there is microthrombi formation, wherein HLH there is hyperactivation of macrophages, the NK cell and cytokine storm and all those things. The key clinical triad of TTP is thrombocytopenia, MAHA. MAHA is microangiopathic hemolytic anemia, which will show more of cystocytes and neurological symptoms. Wherein HLH we have fever, splenomegaly, cytopenia, and hyperphosphatemia. The lab clues in TTP is cystocytes, whereas in HLH it is hyperphosphatemia. The primary organ involved in TTP is CNS, wherein HLH is liver. And the confirmatory test is Adam 13, where it is you have done. And the first line treatment for TTP is generally plasma exchange and high dose steroids plus minus steroids. And HLH is steroids and corticosteroids. The prognosis is, unfavorable. Long-term prognosis, we have to be careful in TTP. But in HLH, it's a secondary HLH. It's not a primary HLH. So this is in short about the two conditions from my end.
Yes, sir. Yes, sir. And a typical HOS is closest differential diagnosis for TTP.
Yeah. So,
Yes, sir.
so Pranita, you can stop your screen sharing. Yeah. So I would come back to our experts. Your last comment, sir. Bhaiti, sir.
Sir, enjoyed in our routine practice and in our setup. We are not going to that particular extent. Learn down the things and going ahead. And many times, पेशेंट विथ सीवियर एनीमिया पांड्रा कावीळ झाला म्हणून आने वाले हमारे ओपीडी में बहुत ज्यादा इसमें देखते हैं. So differentiation between jaundice and anemia for a population coming to us is difficult one, and patient is lucky enough, Shishir sir and all those team, and outcome was good. Neurological involvement was not there.
Yeah. Thank you, Harish sir. Shishi sir, your comment, please. Shiv Prasad sir, your
Yes,
comment.
It was a nice presentation, Shashi sir, well managed, and we have learned a lot from this case.
Yes.
Yeah. I invite comment from Sanjay Pakmade sir.
Really wonderful presentation from Pranita. Really, she presented very confidently, and really means her presentation was really means praiseworthy. And with the Shishir sir, with her, the Shishir sir has done a very, very good job, and the case was very well managed. And both of our experts have given a means even though they missed the diagnosis, but they have explained everything whenever the case was means handed over to them. And so it was a nice and wonderful way of cracking the case. No doubt, we even if we don't need, reach the diagnosis, but still the way we approach that particular case and go for the discussion, that helped a lot to the attendees, and we all learned very much from this particular presentation and the case. So once again, I thank you all from the MahaIP platform, Harish Bahiti sir, Shivprasad Mundada sir, Shishir sir, and Pranita.
Thanks.
Thank you, President
Thank you.
sir. We have Dr. Ravindra Sonana, who happens to be a professor in medical college. We would like to have a short input about the case and his remarks.
सर मराठीत बोलतो मी.
हो.
तर संजय पाकमोडे सरांनी आता बोललं की आपलं डायग्नोसिस नाही झालं, पण व्हॉट इज इम्पॉर्टंट केस जर्नी अँड दॅट केस प्रोसेस, म्हणजे ज्या पद्धतीने केस प्रेझेंट केली किंवा अप्रोच केला, तर दॅट वॉज इम्पॉर्टंट. आणि तुम्ही पण शेख सरांनी पण टीटीपी आणि HLH बद्दल एकदम व्यवस्थित सांगितलं, आणि शिशिर सर आणि बहेती सरांनी ते व्यवस्थित मॉडरेट केलं, त्यामुळे छान केस छान झाली होती.
Thank you, Abba Saab. Yeah, so with this, we are on the last leg of this presentation, that is vote of thanks. On behalf of the entire Maharashtra IIP, we sincerely thank our presenter to begin with, Dr. Pranita. The case was excellent, well presented, well prepared, nicely worked up, and the outcome has been good. So this is what exactly in a clinical setting we want. So Pranita, you presented very well. Your confidence level was very good. You were very clear, and heartiest congratulations to you. So also to your mentor, Dr. Shishir Murgunde sir, it was expected it will be good. As whenever Dr. Shishir is there, it is bound to be good, but he put extra efforts to make it better. So thank you, Shishir sir, for accepting the invitation, being the moderator of this particular case and coming out with a good case and an excellent presenter. So also we thank my senior Harish Bahiti sir, who was kind enough to accept this challenge and done wonderful. Harish Bahiti sir happens to be our senior at IGMC Nagpur, and he was our mentor. So thank you sir. And so also Dr. Shishir, our Shivprasad Mundada sir, very clear, to the point, and a proper methodical case dissection. So thank you, Mundada sir, for consenting the part of this program. And as rightly said, the approach is important. The diagnosis will be there, but what is important is the right approach. And our the presenting team, so also our experts have done well. Thank you for being the part of this journey. We'll meet again the 4th Friday of next week. Thank you, MahaIP. Thank you all for. And the last is our support team, including Pallavi madam from Nasik. She has always been kind to be part of this technical support, and also our delegate. So thank you. Good night. See you again. Bye.
Yes. Thank you very much, sir.
Thank you, sir, Harish sir.